So to continue with this cardiac physiology, so we have seen up to this how much percentage of the blood is going to brain, 15%, kidneys it is going around 20%, pulmonary circulation about 10%. So next part is baroreceptors. Just you just see this word baro. Baro is supposed to be the pressure something. Pressure, barometer is like a pressure, and receptors who are detecting the pressure. What pressure? This is detecting the partial pressure of oxygen. So there are two types of receptors. One is in the arch carotid. Common carotid artery is divided into internal and external carotid. This is called as carotid arch. So beginning of internal carotid artery, suppose this is internal carotid artery, this is external carotid artery, and this is the common carotid artery. So here there are, at the beginning of internal carotid, there is that is called as carotid sinus. Carotid sinus. They have got the baroreceptors, and another is the aortic arch. This is the arch of aorta. So this is aortic baroreceptors, and this is carotid baroreceptors. So aortic, they have got a stretch receptor, felt increasing blood pressure, aortic and carotid, and cause. Whenever there is increase, they detect the pressure. Whenever there is stretch, they detect the pressure as well as partial pressure of oxygen. Two things. They detect the pressure, they get stretched, so it stimulates. So from here, vagus nerve. This is also carrying vagus nerve. And another artery, this is the glossopharyngeal. This 19th, 10th. Two nerves are carrying it. Stretch. Stretch means increase blood pressure. They are detecting blood pressure is increasing. So what to do? They cause inhibition to drop. They decrease the. What is Cushing stride? Now again you have to understand Cushing stride. These are three things. One is increased blood pressure, that decreases heart rate and respiratory rate. Two things are getting down, blood pressure is increasing. So whenever these are stimulated, stretch receptor are stimulated, they sense the reflex to reduce the heart rate. The stretch receptor felt decreasing blood pressure, carotid. So if carotid they get and cause sympathetic stimulation in hemorrhagic shock. Whenever there is, so this is carotid sinus. This one is detecting the decreasing blood pressure, and they cause vasoconstriction and they try to increase. So these are the receptors which alter the blood pressure. Whenever blood pressure increases, that decreases the heart rate. Whenever blood pressure goes down, that stimulates the parasympathetic to sympathetic. Through sympathetic, there is vasoconstriction, and through parasympathetic vagus, there is vasodilatation, decrease in heart rate. Coronary perfusion pressure. Coronary perfusion, it is the from this aortic. There are the coronary vessels are there. Aortic arch. Aortic diastolic pressure. Diastolic pressure minus left ventricular pressure gives coronary perfusion. Depend on the end diastolic volume. Whenever end diastolic volume goes down, the perfusion pressure will be going. Coronary flow occurs mainly during diastole. So pathological tachycardia leads to decreased diastolic time interval. So diastolic time interval is important. Diastolic time interval. This is the question. Diastolic time interval. Coronary autoregulation mediated mainly by the metabolic regulation due to increased cardiac metabolism and release of adenosine nitrous oxide, T3 oxygen increase and lactate. This causes coronary vasodilatation. Coronary vasospasm causes increased calcium in the smooth muscles of the blood, causing angina. So whenever there is spasm in the coronary vessels, that increases calcium in the smooth muscles, causing angina. How is the cerebral circulation maintained? Cerebral perfusion pressure, CPP, is always equal to mean arterial pressure minus intracranial pressure. So MAP is equal to systolic blood pressure plus 2 into diastolic blood pressure divided by 3 is MAP. So to calculate CPP, you have to see systolic blood minus diastolic, systolic blood pressure plus 2 into diastolic blood pressure divided by 3 minus intracranial pressure. They will give coronary perfusion pressure. Increase in oxygen causes increase in carbon dioxide. CO2 when increases, there is cerebral vasodilatation. So hyperventilation that causes respiratory and decrease partial pressure of CO2 to decrease intracranial tension. So intracranial tension, what does it causes? Headache, vomitings, altered mental sensation, visual disturbances, then convulsions, neurological deficit. So this is Cushing's stride. What happens in Cushing's stride? This leads to increase blood pressure, decrease heart rate, and decrease respiration. This is increased blood pressure, decrease heart rate, decrease respiration. Triad. BP is on the top, it is increasing, heart rate and respiratory rate both are going down. This is Cushing's stride. BP increase by increased intracranial pressure causes sympathetic vasoconstriction, so increasing BP. Heart rate caused by barotraceous stimuli leads to parasympathetic. The sympathetic causes increase. Increased blood pressure causes increased intracranial pressure, leading to sympathetic causes increased blood pressure. Parasympathetic is causing due to vagus nerve, it stimulates to decrease the heart rate. Measure of decreasing intracranial tension, head tilt. Whenever, if what you want to decrease the intracranial tension, you have to make head up 15 to 30 degree, analgesia and sedation, prevent hyperthermia, hypertonic saline or mannitol. This is the thing which we have to give: mannitol, diuresis or hypertonic saline, mild hypocapnia by hyperventilation. So if you do hyperventilate, that can cause mild hypocapnia. Filtration pressure is, how is this? Always the capillary and the lymph and in between the tissues are there. Capillary filtration pressure depends upon capillary colloid osmotic pressure. Osmotic pressure tries to draw the fluid inside, filtration pressure tries to draw the fluid outside. It is capillary filtration pressure minus colloid pressure will definitely cause leaking. So hydrostatic pressure of the capillary plus oncotic pressure of the tissues. So oncotic pressure of the capillary plus hydrostatic pressure of the tissues. It's like this. This is tissue hydrostatic pressure, this is capillary filtration pressure. They are opposing each other. Tissue colloid osmotic pressure is trying to draw inside. Capillary colloid pressure is trying to draw fluid inside. So net result will be difference of this, difference to like this. So definition: shock. Inadequate tissue perfusion is defined as shock. Different types of shock: hypovolumic, definitely the volume of the blood goes down either in hemorrhage or dehydration or less blood because of any other condition, that is hypovolumic. Obstructive shock means the heart is not pumping, there may be compression of the heart, tension pneumothorax or cardiac tamponade. Cardiogenic, there is pathology itself in the muscles of the heart, that is myocardial infarction or heart failure. Distributive means the fluids which is distributed all over the body. If there is generalized vasodilatation, that is the fluids is distributed. It may be found in neurogenic, spinal, anaphylactic or septic. So what happens? Systemic vascular resistance. This is one is causing to maintain blood pressure. When it is because of vasoconstriction. Vasoconstriction increases SVR. So increase SVR, vasoconstriction in cardiogenic shock. The body is trying to compensate by causing vasoconstriction. When blood pressure goes down, JVP is increasing, jugular venous pressure. In hemorrhagic shock, again, in all types of shock, blood pressure has to be low. So JVP is also low in hemorrhagic shock as there is less blood. But vasoconstriction is there, is a compensatory mechanism. Vasoconstriction that increases SVR. Whether in systemic neurogenic shock or septic shock, there is vasodilatation because of release of vasodilators. So these vasodilators, all these bradykinin and all these fluid substances, they cause vasodilation generalized. So increase or normal cardiac output may be increased and heart rate is also increased in septic shock. While neurogenic shock, everything is down. So let's come into hemorrhagic shock. It depends upon how much blood is lost. If less than 750 ml or up to 1500 ml, there is no change in blood pressure. The heart rate may be above 100. Pulse pressure is normal or going down. Capillary filling less than 2 seconds. Respiratory rate is again 14 to 20 in first class. This is the worst. Class 1, class 2, class 3, class 4. If it is more than 1500 to 2000 ml, it is class 3. If it goes about 2 liters, 2000 ml, it is class 4. So around 40% of the blood is lost. Till 15 to 30% person is not having any change in the blood pressure. From here, blood pressure and heart rate goes, either blood pressure goes down, heart rate increases to 120. So heart rate is increasing as BP goes down to maintain the supply of the blood to the capillaries and the vessels. Then respiratory rate automatically it is also increasing. 14 to 20 is normal, 20 to 30 is for class 2. More than 40 blood pressure, pulse rate is more than 40, blood pressure is very low, and respiratory is more than 40. This is class 4. Urine output is negligible, 30 or more in 70 kg man. It has to be there 0.5 ml per kg per hour, 0.5 ml per kg per hour. Should be urine. Mental state is anxious, mildly anxious, confused. So cardiogenic shock, that was hemorrhage. Cardiogenic shock, there is pathology with the heart, either cardiac tamponade or tamponade is obstructive type, and cardiogenic is itself, muscle itself. Angina pectoris, clinical feature is blood pressure is decreased, JVP is increased. Pathology, contractility is less, stroke volume is less. Cardiac tamponade, history of stab wound mainly, muffled heart sounds, decreased BP and JVP increased. Back straight, JVP is raised, heart rate goes down, muffled, and blood pressure is less. This stab in the heart that is leading to back straight. Anaphylactic shock, there is injection of penicillin or bee sting, suddenly circumvenous hypertension. Treatment is by intramuscular or subcutaneous adrenaline. This is the question, why you get intramuscular subcutaneous adrenaline. So septic shock because of infection, cystic inflammatory response syndrome, 2 or more of the criteria. Here there is a respiratory rate. Rates are there: heart rate, respiratory rate, temperature, TLC. Respiratory rate more than 20, heart rate more than 90, 20, 90, temperature 36 and 38, and TLC 4 and 12. Sepsis is documented infection, 2 or more criteria. Severe sepsis, sepsis with organ function, septic shock, refractory hypotension. Now SOFA score. Sequential organ failure assessment. Sequential organ failure assessment. So one after another, different organs are getting into failure. Sequential organ failure assessment is used in predicting outcome of the critical patient. How it is the outcome? So first of all, you see in the lungs what is PaO2, partial pressure of oxygen, to FiO2. So if it is more than 400, it's 0, less than 100, 400, 300, 200, 100. So it's 4 score. Then second is neurovascular. You see Glasgow Coma Scale 15, 13 to 14, 10. Then liver function test. Again there is child's criteria like this. Liver function, Glasgow. Bilirubin level is measured here. Coagulation profile. Bilirubin more than, less than 1.2, 1.2 or so it goes above 12 means liver failure. Coagulation profile, platelet count, if it's decreasing to low level, it's increasing. But cardiovascular, use measure mean arterial pressure, more than 70 it's normal. Even after dopamine, it's not increasing. Dopamine, epinephrine, norepinephrine. So kidney scores, creatine level is measured here, and urine output is also measured. So creatine is rising and urine output is going down. Maximum SOFA score, if it is 0 to 6, so less than 10 mortality. More than 50% mortality is 13 to 14. Q SOFA score, bedside tool used for assess the septic shock in the manner, systolic blood pressure, respiratory rate, Glasgow Coma Scale. So bedside tool, Glasgow Coma, you can measure there only respiratory pressure and systolic blood pressure. Shock with warm peripheries, treatment by noradrenaline, mainly C protein may be used. C proteins. So most of the time in DIC and all that, if person goes into noradrenaline has to be used, sepsis. Now, response to the shock. Nervous response. Baroreceptor is the first thing to be affected in shock to correct it. Stretch receptors in the wall of carotid and aortic receptors send its afferent. So, baroreceptors come first. These are the stretch in the wall of carotid and aortic sinus and send afferent to cardiovascular control blood pressure by stimulation of sympathetic nervous system. Then second is the hormonal. Second is hormonal. Renin, angiotensin, aldosterone, renin for juxtagonal cells, which convert angiotensin to insulin, which is converted to ADH and vasopressin then comes into action to prevent loss of blood. Medulla, adrenaline, non-adrenaline, sympathetic system in non-adrenaline. Medulla is adrenaline. Vasoconstrictors and vasodilators. Vasodilators are histamine, prostaglandins, nitric oxide, serotonin is the vasoconstrictor. Both vasoconstrictor dopamine. Drugs and the receptors. Adrenergic receptors. Alpha receptors are seen in the blood vessels, which cause vasoconstriction. Beta receptor, beta 1 are seen on the heart, which increases the causality, and beta 2 are in the vasodilatation. So this is about the drugs which are most commonly used in septic shock. Noradrenaline is commonly used. Dobutamine is the cardiogenic shock. Dopamine is again cardiogenic shock. Isoprenaline harden increases cardiac output. Meloprenin, adrenaline is used in anaphylaxis. Epinephrine again hypotension. So this is about the cardiology, physiology.